Welcome you all. We are going to start our 2-day PG orientation program. It is aimed only for your exam. So, don't feel shy to ask any question to your teachers. So, we are organizing this program for last 6 years. For last 2 years, this program is organized throughout India in different centers for last 2 years by AY. And there will be classes. You will get teachers from all the medical colleges throughout West Bengal, and also there will be one AY observer. So we will start our first session on COM. Moderator Dr. S.N. Bandopadhyay, HOD Medical College Kolkata, and editor I. Jones. And the panelists are Colonel Ajay Mollik, HOD AIMS Kollani and Medical Super, Arindam Das, SSKM Hospital, Soikot Samadar, Dr. Soikot Samadar, SSKM, Dr. Jayanto Saha, HOD Arjikar Medical College, Dr. Sobhyasachi Gon, HOD IQCT Durgapur, and Dr. Ajay Khawas from KPC Medical College. Sir, please take on the mic.
We will be starting the day with discussion on chronic otitis media. Almost all of you will get chronic otitis media as a long case if it is available. So it is the most important one. So we will be starting the day with discussion on chronic otitis media. We will gradually move on from one topic to another, but it will not be a didactic lecture. So we will put the questions to you, and from the back we will hand over the microphone to one after another. You give your answer, don't keep mum, because silence will not earn you any points during the exam. You know everything. Now we will have to discuss how to appear in the exam, how to give your answers, how to format your answers, how to face the examiner, how to satisfy the examiner's queries. So whenever the microphone is with you, you will have to answer and pass over the microphone to the next one for the next question. You have the liberty to give the wrong answer, but don't keep mum. So we will be starting the day with chronic otitis media squamous disease. I will give a very short description to orient you with the condition of the patient. So 42 years old male patient presented with chief complaints of discharge from both the ears for 6 months, deterioration of the hearing in both the ears for 4 months, and spinning sensation during the last 1 week. The history of present illness, the disease started insidiously, but the discharge actually is thick, persistent, without any aggravating or relieving factors. The hearing gradually deteriorated. So first thing is the chief complaints, where you write the chief complaints. You enumerate the chief complaints without need to write a full sentence. So chief complaint dash duration in chronological order. Now comes the history of present illness. Each of the chief complaints will have to be described that lead to your final diagnosis. So how the discharge is disturbing the patient, what is the character of the discharge, how the discharge is improving or deteriorating. So I am not going to elaborate on these things. And the negative histories, important negative histories. Here the facial nerve function is normal, there is no history of facial weakness, no history of trauma, no history of previous surgeries. You will have to mention all these things. And the past history, family history, I am not going in details because this PowerPoint presentation will be shared with you. You know how to write the history. The history should be in detail, but you will have 45 minutes for completing your long case. So it will be around half an hour for you to complete the writing the history. So don't elaborate too much, just points and points in favor of diagnosis and point that excludes the differential diagnosis. So come to the loco-regional examination. It will be discussed by Colonel Mollik later. But there should be two columns for the left ear, for the right ear. Here, how can you move on from the pinna, pre and post-auricular region, then examination of the introitus, without examination of the ear, without oral speculum, and after that with the speculum. In this case, the patient has an oral polyp in the right ear with a attic retraction pocket, and it is grade 4, I should say, because there is erosion of the scutum, and on the left side there is a posterior superior retraction pocket and also grade 2 attic retraction. The tuning fork tests suggest that there is a severe sensory mixed hearing loss in the right ear and moderate conductive hearing loss on the left ear. But you will have to write the examination part of the other part. So nose and throat should also be written in detail. The examination of the nose and throat should also be written in the detail. And ultimately there will be a summary of the case with the chief complaints, the history of present illness, the important negative points, your findings and your diagnosis. Now the summary should not be too elaborate. You will have to complete writing this history within 30 minutes. Remember it. So the diagnosis becomes chronic otitis media. Don't write right ear chronic otitis media because we will be sharing one history sheet that is corrected, that has been corrected. So you know where do we make mistakes. The English language should be acceptable. It is not right ear chronic otitis media. It is chronic otitis media. If you read the first part, it is the diagnosis. Chronic otitis media. Now give the adjectives. So it is Comer's disease. Which stage? Which year? And what are the important findings and with or without any complication. Here the patient has reeling sensation where the fistula test is positive. So it has a complication. So this should be the diagnosis. Diagnosis should be complete, but it should be written in proper format. So I will now ask Dr. Ajay Khawas to discuss the history part.
Good morning. So, Dr. Bandyopadhyay sir already discussed the history taking. The importance of the history taking. First is the chief complaints. From the chief complaints, you make a broad hypothesis. When you go for the history of present illness, then it is the narrow hypothesis. Then physical examination. After the physical examination, it become a provisional diagnosis. Also make the differential diagnosis. That's the thing you have to do. Next, after that is the investigation. Investigation you have done, then it is the final diagnosis. Then you proceed for the treatment. So, if you take the history properly in the COM case particularly, your diagnosis and the examination, if you do properly, then it will be 99% your diagnosis will be complete in COM. Next, sir already described how to describe the discharge character. It will be described amount, consistency, all the things you should mention. Now, how to present the history. use in simple language as a short sentence, already Sarah has told, in a flowing manner, in a just like storytelling, not a break. It will be in the storytelling manner, and avoid the repetitions. That means once you write in the history, prehistory of illness, again you are going to the repeat in the some others area. That is not. Also take only the salience that is necessary for the negative history. Not too much negative history is required. And the details should be kept in the systemic review and negative history in a short time, in a time tracking manner. So now come to the few questions. So what are the points? You have seen, gone through the case. So what are the point in favor of active, you have diagnosed the squamous cell disease. What are the points from the history? Anyone? Last one. Huh?
Continuous,
Continuous,
scanty amount,
scanty,
mucopurulent type of discharge.
mucopurulent.
It was purulent.
Next one.
So color would be like greenish or yellowish greenish, then purulent ear discharge and foul smelling
Yes.
and maybe sometimes blood tinged.
Yes. Okay. So from the history, it is a persistent discharge, foul smelling, and the consistency, all things you have to mention. So when you will get the purulent ear discharge in purulent ear discharge?
Sir, in mastoiditis or furunculosis,
Mastoiditis? Purulent ear discharge. Next.
In case of any mucosal disease also you can find that purulent ear discharge.
No, mucosal disease, it is a mucopurulent or mucoid discharge.
if there is any squamosal disease,
Yes.
if there is any furunculosis,
Yes, otitis externa
otitis
sometimes.
externa.
Then next the mucoid discharge, that is already discussed. That is mucoid discharge is seen in mucosal variety. So mucopurulent ear discharge. Mucopurulent ear discharge.
Otitis externa,
No. Mucopurulent.
second.
Secondary
Okay,
infection,
sorry.
bacterial infections.
COM with mucosal variety with bacterial infection. Sorry. Next is the serous discharge, usually find serous discharge in case of CSF otorrhea. Smell of cholesteatoma? Rotten fish. Rotten fish. Why the foul smelling discharge? While the foul smelling discharge.
So because of the bone eroding property, osteolysis happens and that gives that foul fishy smell with anaerobic infections.
Yes, anaerobic infection is also important. Next. Blood stain discharge. Blood stain discharge seen in?
So blood stain discharge is seen in case of malignancy if there is polyp or any granulation tissue.
Also in squamous cell disease. Blood stain, frank blood seen in malignancy.
Yes.
When the PN in COM indicates? PN in COM indicates?
If there is any intracranial involvement,
Huh?
facial nerve involvement or
Facial nerve involvement, there will be no pain.
no, intracranial
Intracranial, that will be headache.
Yeah.
Sir, in mastoiditis.
Mastoiditis, otitis externa. So with the short time, I will going to the next questions. Features of tuberculous otitis media? That's sometime asked. That's why I am skipping some questions. These all questions answer will be you will get at the study material. So I am just skipping. Features of tuberculous otitis media.
Sir, there is a multiple perforation in the tympanic membrane and fever and all the others are tuberculosis, normal tuberculosis symptoms like fever, weight loss and other features.
Close to the mic. Closely.
Acha, sorry. There is a multiple perforation on the tympanic membrane, first feature, and there is a mucopurulent discharge if involved the middle ear mucosa also. Sorry, sir.
Sir, multiple perforation, pale mucosa, may be presence of granulation tissue.
Yes, sir. Granulation tissue and some out of proportion hearing loss.
Out of proportion hearing loss. That is the important thing.
Yes, sir. Yes.
So, last question. Why normal ear should be examined first?
Sir, to compare the both tympanic membrane, to compare the non-pathological site first, to compare with the pathological site.
Any
and
other?
arekta hoche sir infection.
Yes, that is also important. Yes. The spread of infection from one ear to other. Okay. Next.
Thank you, sir.
Next, Dr. Sobbosachi gone. No, Dr. Jayanto Shah, sir.
Okay, right ear findings.
Okay, so there is a polypoidal mass present in the right ear, and along with that there is attic retraction.
See, can you be more descriptive?
Okay, so there is a polypoidal mass.
Which part of the canal? It is occupying the full canal, yes or no?
So it's occupying the part corresponding to the pars tensa.
Yeah, so mention that then.
And there
it's
is
a polypoidal mass.
Polypoidal mass.
Color of the
color
mucosa.
is pinkish color.
Okay. Anything else you're finding on that?
So some amount of whitish debris is present over
discharge.
the...
See,
yes,
it is a kind of a yellowish discharge, right?
Discharge
so
present
this
over
makes it very, this will tell you about activity also. There is an active discharge.
Active discharge.
It is telling
disease.
you that. Now, you mentioned about the pars tensa. Just pass it on. Describe the pars flaccida. Right here. He's already mentioned a little bit about it.
Sir, there is a retraction over pars flaccida. It may be grade 4 pars flaccida retraction.
No, before you cannot be maybe. You have to be very specific. You're seeing it, you say what you are seeing. So if you cannot see, now classify, what is the classification of pars tensa? You know the classification?
Yes.
There's a name for that?
Yes, sir.
What is the name?
Sets and Thos classification. Sir.
Great. So now you just tell me where do you feel it is going to be? 1, 2, 3, 4.
Sir, it will be grade 4 pars.
Why?
Because there is scutum erosion, sir.
1, great. See, I was talking to some people in the morning. Don't mug up things. Try to understand what is in the grading which you are trying to see. 1 is how much the flaccida is going back. 2 is the scutum. And 3rd is whether you can see the fundus. So just describe these 3 points. That's all. Your answer is coming. So can you see the fundus? Okay. You may say yes or no. I am not seeing. I am seeing it. Fundus may be seen, not seen. Okay. So immediately fundus not seen goes to grade?
Grade 3, sir.
No, 4.
4.
Okay. So just say if you are not seeing it, grade 4. Right. Now next. Come to the next. Similarly, in the grade, if you are having the past tense, you have to try to give your grade. Once you know so much, give your best, right? So describe it properly, describe the factors, you have described the mucosa, you have described what you are seeing, you have described the discharge, and finally you say your grading over there, right? So now come to the left here. Let's improve on that. He's already drawn beautifully, a diagram is already given to you. But these are the tricky questions. So come to past tense, left here.
So there is also retraction is there.
Mic to Prakash.
Retraction is there, sir. Retraction.
Continue, keep saying.
And handle of malleus is seen also properly.
Findings. I can't hear you. Okay, pass on next. There's shortage of time, so I'm just passing on, okay?
There is a posterior superior retraction pocket, and there is also retraction in the attic, sir.
There is also?
Retraction in the attic, sir.
Okay. Posterior, let's go to the past tense only. Can you do better than just telling there is a perforation? You have a concept of quadrants?
Yes, sir.
So just tell the quadrants. You have a concept of size?
Yes.
So now start off like that.
So it's a left-sided posterior superior.
Okay. Carry on, good. What else would you like to describe? Next. Change to next.
There is a posterior superior retraction. The incudostapesial joint is seen. It is wrapped around, so it might be grade 3 retraction.
Okay. What else would you like to describe? Anything else is part tensor?
Other parts of the pars tensa is sclerosed,
Okay.
and the pearly white color is not seen.
See, when you describe, now I'll tell you. Once you're describing the perforation, so you have to describe the margins of the perforation. It makes very significant. Is it rounded or is it sharp? Is it ragged? It's got a significance, okay? In chronic, you will get a rounded, nice margin. Sharp is more active. If it is ragged, it can be traumatic. Then you come inside. So first is where it is. You already said posterior superior. Somebody can say extending into posterior inferior quadrant. Then what are you seeing inside? How is the mucosa inside? In this side you had discharge. Do you have any discharge?
No,
what is the color of the mucosa inside? Right?
Yes,
Then what are the structures you are seeing? Besides you are seeing can you describe the IS joint?
The incudostapedial joint is
Is it
seen.
normal?
It is not normal.
Yeah, so why did you describe that? That gives you those extra points of observation, right? And okay, so rest of the TM you have mentioned. Next, come on to the past, time table. Ajay, time table. 30 seconds, past tensa, past placida, same, improve on it. Past placida or left? What are you seeing? Describe it.
Sir, it's pars placida is also retracted grade.
See, give the 3 points what I told you. It is retracted.
No, retracted, but no.
Can you make out about the scutum? Just say the scutum is.
Cannot.
If you cannot make out, keep quiet. Can you see the fundus?
No,
you
sir.
cannot see. So just say that, sir, there is a retraction in the pars placida. In the center of the pars placida, is it occupying the full pars placida? No. In the center of the pars placida, overlooking the neck of malleus and the head of malleus, right? Then I cannot see the fundus of the thing. There is no cholesterol flake seen. Correct? So that covers your thing. Okay. Next question to you is, we have finished this part. Now next is, in that examination you do a mastoid, how will you make out mastoid tenderness or complication? Mastoid tenderness examination, what do you do?
So we it's a 3-finger test.
Yeah, describe it.
First is index finger is put over the mastoid. And the conchal groove, another finger is kept, and then we check for tenderness over the region. And the middle finger
So
is
what is it identifying? Concha, what is it identifying? Simba concha?
Simba concha, mastoid tip.
So Simba concha, what do you, if you have tenderness, what does it tell you in an adult? Yeah.
Arthritis, inflammation of the, there is, sir, mastoiditis is present if there is, if we press it
Specifically if you are pressing it here. Antrum. Pechone?
here. Mastoid tip.
And tip. And third is in the tip. So it's a three-finger test,
Three-finger test.
right? Tuning fork bolbo. Tuning fork? Okay, next. Okay. How will you do the fistula test? And what is the significance?
Sir, we alternately occlude and occlude the by pressing the triggers. Alternatively, we see if there is any nystagmus present in the.
Even though you not get nystagmus, whether the patient is complaining of any dizziness. Is there any other way you can do it?
Seagull speculation.
Great. So you can do it by the Seagull speculation. So what does it tell you? Where is that fistula commonly in a COM case?
Lateral semicircular canal.
Great. That is the most likely site. That is the lateral semicircular. Okay, tuning fork. Next. For us, it is a race against time. Soumya is very particular and Ajay is very particular. We go on time. So just asking that. Okay. Tuning fork test. Describe.
First, the tuning fork need to be.
Bolo. What? This is the findings.
Hit it on a padded surface. Usually.
Okay. He is giving you the findings. There are both sides negative in all. Serial Weber is lateralized to the right and ABC is reduced on the right and not on the left. What does it tell you?
ABC reduced.
Very specific to this case.
Weber. Right.
Describe these findings.
Okay. Weber is lateralized to the left side and ABC reduced to the opposite side.
Yeah, so what is it? What is your inference?
There is a.
Chalo, next.
No, bole.
Pass it on. Let's see. We'll just. It's for everybody. Everybody should get a chance.
Sir, Rini is negative in both ears, so there is conductive hearing loss in both ears, and the Weber is lateralized to the right, so right is the worst ear. And also, since in serial tuning fork test, I see in 1024 hertz, it is positive in the left ear, means there is moderate hearing loss maybe, and in the right ear, it might be severe hearing loss as it is negative in all three frequencies.
But you didn't mention anything about ABC. Look at the ABC. What is it telling you?
There is also bone mixed hearing loss, as bone conduction is also reduced, so it is mixed hearing.
So there is a mixed.
In right side.
In the right side. Please answer clear and concisely. Be very specific. These kind of cases you may get caught because both ears are involved. If it is 1 ear, generally you are okay. Now, can you tell me from this which is the worst ear and why? Next.
Sir, right ear.
Next. Which is the worst ear, given the choice of you operate on the worst ear, which is the worst ear and why do you say so?
Sir, right ear is worse because the Weber is lateralized to right ear. And also in the absolute bone conduction test, the right ear has reduced sensation as compared to the examiner.
You said Weber is lateralized to right ear.
Yes, sir.
Can it be because of an effect on the left ear? Not in this case.
Yes, sir.
How? If you just give a line, Weber is lateralized to right ear, therefore the right ear is bad. I say no. Am I correct? He's nodding his head. Give it to him.
Sir, can be sensorineural hearing loss in the left ear also?
Absolutely correct. You can have a SNHL. So please, when you're describing, take home message, when you're describing the tuning fork tests, analyze all the tests first, see both sides and then give your answer. Don't jump of just saying Rini and then you land up in trouble. Okay? So please analyze all three and then you talk. Right? Yeah. We can discuss this later on. Next.
So, after taking the history and finishing the examination, you have got a provisional diagnosis. What are the points in favor of your diagnosis?
In history, the characteristic of discharge, scanty, continuous, foul smelling, blood stained, Also on examination of the
First tell
tympanic
the duration. First you have
duration.
the duration, hearing loss,
Yeah.
both for discharge and both for, yeah, for
Also the
hearing loss.
otoscopic finding with attic retraction.
Completing the, tell more some points from history. 4 to 5 points.
Scanty, continuous, foul smelling, blood
Yeah.
stain discharge, persistent discharge.
Whether he has got any dizziness or not, vertigo or not,
Yes.
tinnitus.
Patient in last month had a dizziness.
Then come to
Examination. Yeah.
Findings. What are the findings in favor of your diagnosis?
Yes.
Findings that favors your diagnosis.
Sir, in the right ear, there was mucopurulent discharge present, attic retraction was there, oral polyp was seen.
What may be the findings you can expect in squamosal variety in external auditory canal? Do you know? That also, here it is not present, but
Cholesteatoma can be seen,
sagging.
sagging.
Now, what are the differential diagnoses?
Said there may be any underlying malignancy.
Yes.
Or maybe dual pathology, means any mucosal variety, they get converted to squamosal one.
Dr. Khawash already discussed about the tubercular otitis media.
TB है, tuberculosis media.
Tubercular otitis media, temporal bone CA, granular myelinitis, otitis externa maybe. How will you proceed in this case?
I will first examine the ear under microscope, and
why?
I have to confirm my otoscopic finding with, and if I get pass, and I can send it for the culture, and also I will consider
With the better magnification.
Yes, and also we will go for the Piotton audiometry test for this test.
Radiological
investigation.
Yes.
And after that we will proceed for
Each and every case you can perform the CT scan conventionally or
conventionally we don't require, but recently if you have the availability in your institute, then we will go
afford.
for the
If patient can afford, each and every case you can go for. Okay. Next, what is the sequence of involvement of ossicular chain?
What is the sequence of involvement of the ossicular chain? Which part of the ossicular chain undergoes?
Okay, sir. First, neck of incus. Necrosis. First is the handle of malleus. We can see.
Next.
Sir, first long process of incus.
More precise. Oh. Next.
The long process of incus, then suprastructure of stapes.
Actually,
sir, first is lenticular process of incus, then long process of incus, then is suprastructure of stapes.
that is for first tensor cholesteatoma.
Yep,
But in attic cholesteatoma, first malleus head.
Oh, first
okay.
malleus.
Next, why is retraction pocket is more common in posterior superior region?
So the posterior superior region is already suffering from lack of ventilation because of the presence of mucosal folds and ossicles.
That is the older view.
Sir?
Newer
view.
Next, very important.
Sir, there are 3 points that are why the posterior superior region is more common. The first one is, sir, the first one is the posterior superior region of the pars tensa is shallow than the rest of the pars tensa region. And the second one is it is more vascular, so any kind of inflammation, there is increased oxidation stress and increased inflammation and granulation tissue. So the ventilation gets hampered first here.
More release of collagenase
yeah,
enzyme and collagen
yes,
fiber will be distracted.
Yes, sir. And in the posterior superior region, the fibrous layer of the pars tensa is less organized than the rest of the tympanic membrane.
So there are 3 salient feature points: more vascular, that cause inflammation, collagenase, and that cause the collagen destruction of that layer. And middle fibrous layer lacks well developed circular layers, and the third one is weak annulus insertion. In this case, there is a mixed hearing loss.
So because of the
How do you explain?
Long-term history, then is long-term usage of the topical antibiotics, ototoxic antibiotics, and
which group of
Neoma, long-term
aminoglycoside? More important
is
pathological, more important pathology for SN loss.
So labyrinthitis, if we develop.
Next.
Outer hair cell.
Only outer hair cell. How it can be distracted? Involvement. How? Bacterial endotoxin permeates through round window and inflammation into the cochlea. ঠিক আছে? Next. So there are direct invasion by pathogens, ossicular chain erosion and fistula formation, ototoxic medication, and defined inflammatory markers. Next. Question: factors affecting aggressiveness of cholesteatoma. What are the factors?
Sir, middle ear dysventilation, long-term chronic otitis media, eustachian tube dysfunction.
These are the factors: VEGF, EGF, TGF alpha, interleukin 8 that cause angiogenesis, and within perimetrics, and that actually helps in neovascularization, and that helps the nutrition to formation of more cholesteatoma and for aggressiveness. Okay. Common question: pathways of spread of infection.
Sir, the common pathways follows the ventilation route of the middle ear from the mesotympanum into the mastoid antrum, and from the pars flaccida it may goes via the epitympanum and the attic region, and then go to posteriorly towards the mastoid.
Direct bone invasion, venous thrombophlebitis, and preformed pathways. Now, you have seen that in right ear there is a attic cholesteatoma. Suppose, assuming that your patient has got developed mastoiditis, how you can explain in that scenario? Attic cholesteatoma, mastoiditis.
Attic cholesteatoma will spread to the mastoid.
Actually, I want to know the spread of cholesteatoma.
Through superior incudal space, then pouch of Walrasch, then mastoid antrum, then through Otitis, mastoid antrum, then mastoiditis.
What is the pathway? How superior incudal space it can
through the pouch
encroach?
Through the pouch of Walrasch, it will proceed.
From Prusak space to, there is a gap between lateral malleolar fold and lateral incudal fold. There is a gap that ultimately leads to superior incudal space and Aditas,
Aditas,
and
then
antrum.
So good morning everyone. The only thing that you need to be precise about is your discipline of how you speak. That is the most important thing in presentation during the exam. Everyone knows each and everything. I will assume that everyone knows each and everything. Now you are at the fag end of your course, so you know everything. So be precise. Now I ask the question, anyone take up the microphone? So how will you manage the case? How will you manage the case? Whenever you are asked about how will you manage the case, what should be your answer?
Sir, as we have been told the history and the examination findings of the patient, so now we will move ahead with the investigations. Then, as someone has said, that we will first do pure tone audiometry.
So you will manage the case by doing some specific investigations and going for surgical intervention.
Surgical
ENT is not MD ENT, it is MS ENT. So always say that you need to do some surgical intervention. So what investigations that you would like to do?
So we will, we have to assess the hearing of the patient, so we will do pure tone audiometry.
Before going into the details, always say that I will go for some specific investigations and for some general investigations. General investigations are for pre-anesthetic fitness of the patient. So what are those specific investigations? Anyone next to you?
For the specific investigations, we will do examination under microscope,
Right.
audiometry. Then
Right.
if radiological investigation could be done and patient can afford, we'll go for HRCT temporal bone to see any bony erosion or what are the structures that could not be seen in microscope.
Fine enough. Only remember the last point, vestibular assessment. Mostly we don't do vestibular assessment in the cases that we are preparing for surgery, but in any developed nation, vestibular assessment is an important part of the investigation battery. Audiometry. I will come to audiometry. So what kind of audiometry that you would like to do for this patient? Anyone next to you? What kind of audiometry? Next, okay. What kind of audiometry?
Pure tone audiometry, sir.
Very good. What is a pure tone audiometry? Next.
So in pure tone audiometry, we give a specific tone at the various frequencies starting from 500 to 4000, and we look for whether there is a conductive hearing loss or sensorineural hearing loss. We quantify,
Make
qualify,
it precise.
quantify
It is
and
a
qualify
graphic, write it down. Pure tone audiometry is a graphic representation of quantitative assessment of a patient's hearing. Pure tone audiometry is a graphic representation of a quantitative assessment of the patient's or subject's hearing. ठीक है? So we do it with a instrument is called a pure tone audiometer, and the graph that we obtain is called a
audiometry, audiogram.
pure tone
Audiogram.
Very good. So we do a pure tone audiometry, that is the test. The graph that we obtain is a pure tone audiogram, and it is done with the help of a pure tone audiometer. Any indication of impedance audiometry? It should be done to check
If there is eustachian tube dysfunction comes under impedance audiometry, so
that is important,
that is important.
perforation and
perforation.
also for medico-legal reasons. ABR is usually not required but required in pediatric population. So going into details of a pure tone audiometry, whenever you are given a pure tone audiogram, first you need to check for the symbols, classify the right and the left ear. If it is a colored audiogram, definitely you will have a very good idea. The right side is in which color?
Red color.
Red. R for R, right side is red, and the left side is usually blue in color or black. Fine. Then there are some specific symbols. No need to mark those symbols up because they will be given along with the graph paper. Each and every graph has a key for the symbols that has been used. Only remember the boxes or anything, if it is marked in bold, then it is a masked one, and if it is not masked in bold or it is not filled up, then it is unmasked. Number one. Number two is the brackets, the side on which it is open is the side being tested. Suppose in this is a, which side open? Right open. Right open. Right open. So it is a right sided symbol. This is left open, left sided symbol. And if it is in third bracket, then it is a masked one. Fine. So, to assess a pure tone audiogram, you first need to assess the pure tone average in which frequencies. Tell me the 3 frequencies in which you will assess. The next one?
500, 1000 and 2000 hertz.
Very good. So why is these 3 frequencies used?
Because first of all, the American Society has given these 3 frequencies as the hearing frequency for the normal hearing of the patient, and also the higher and the lower frequencies are very much negligible.
The term which I am looking for is, these are the speech frequencies. Very good. These are the speech frequencies. So we assess in these frequencies. So what do we assess? We assess the pure tone average of the bone conduction threshold and the air conduction threshold in these frequencies. So which one is the bone conduction curve? This one is the
bone conduction.
Bone conduction. This one is the
air conduction.
Air conduction curve. Because we have read the symbols. Fine. Yes, so what is the pure tone average of the bone conduction threshold of the right ear? For 500 it is around 25.
No.
For 1 kilohertz it is around 35.
35.
And 2 kilohertz it is around 50.
50.
So it will be 25.
25, 40.
Plus?
Plus 40, plus
35
35
plus
50 divided by 3.
Around 35.
Around 35.
Remember, pure tone average for the bone conduction threshold for the right ear is around
35.
35 decibel. Now next one, please calculate the pure tone average threshold for the air conduction curve of the right ear. Next one, next person, please. First which frequency?
Sir, can't see.
Huh?
Can't see what's written.
You can't see?
Sorry.
500.
Sorry, 500. Yeah.
So what is the value? 85.
85.
Then which frequency you will use?
1000.
1000. 1 kilohertz. What is the value?
85. 100.
Around 95.
95.
And for 2
2000
kilohertz it is around 90.
90.
So what will be the average of the air conduction threshold?
80. Around 90.
Around 90 decibel.
90 decibel.
Fine. So 35 and 90. So what is the airborne gap? How will you calculate airborne gap? Airborne gap is gap between these two curves. What is the average airborne gap?
Around
90 minus?
minus 35.
Around 35?
Around 35.
So around 50 decibel. Do you think that the air conduction threshold, bone conduction threshold is normal over here?
No, sir.
35 decibel, is it normal?
No.
So bone conduction threshold is poor.
Poor, yes, sir.
In which condition bone conduction threshold is poor? Next one. Bone conduction threshold is poor in which condition?
SNHL.
Sensory neural hearing loss. Airborne gap is around 50 decibel. So airborne gap is present in what kind of hearing loss?
A conductive hearing loss.
Conductive hearing loss. So this graph shows what kind of hearing loss?
Mixed hearing
So
loss.
it is a graph denoting mixed hearing loss. Fine. So you have calculated the pure tone average of air conduction threshold, pure tone average of bone conduction threshold, the average air bone gap, and you have commented on the type of hearing loss. So pure tone audiometry or a pure tone audiogram gives you an information about 3 important things. What are those 3 things? Next person.
So what is the question again?
A pure tone audiogram gives you information about 3 important characters of hearing loss. What are those 3 things?
So hearing threshold.
So the degree of hearing loss, the amount of hearing loss, then second
type of hearing, sir. Hearing loss.
Very good. So amount of hearing loss, degree of hearing loss, and the type of hearing loss. Quickly, for the left side, next person, say what is the type of hearing loss, degree of hearing loss, amount of hearing loss. We go together for the air conduction curve. For the air conduction curve, see.
40 decibel conductive hearing loss.
Around 40 decibel. The pure tone average of the air conduction curve. For the bone conduction curve, the pure tone average is around 20 decibel. 0 to 25 is normal. So bone conduction is normal. So this is a normal sensory neural component. But airborne gap is present. So this is a curve denoting Conductive hearing loss. So patient has a conductive hearing loss and the pure tone average is 40 decibel. 40 decibel is what degree of hearing loss?
Moderate.
Mild. So 0 to 25 is normal, 25 to 40 is mild, 41 to 55 is moderate, 56 to 70 is moderately severe, 71 to 90, very good, is severe hearing loss, and more than 91 decibel is profound hearing loss. Very good. একটাই জাস্ট জিজ্ঞাসা করে নেওয়ার, this PTA is acceptable to you or not? Masking করা আছে. Bone conduction should always be masked.
If you notice the tuning fork tests done and the PTA are absolutely matching. There is a mixed hearing loss on the right side brought out in the PTA and the left side had a pure conductive element. And from the tuning fork also you can make out the degree of hearing loss. All three have gone. 1024 gone means there is a 60 dB loss, which means there is ossicular. Yes, there is a ossicular erosion. You have to do an ossiculoplasty. So beautifully both the tests are correlating. Okay.
Now be very attentive for the CT scan session. Some part will be on lecture type and some will have to answer. So be very attentive because we are not usually deal with the CT scans in our program. So be careful about how to decode the CT scan.
Okay, so let's start. So we are in between the case presentation of a COM. So here we cannot discuss every aspect of CT scan or radiology of ear or anything. But we first want to discuss how to read the CT scan. What are the components you have to see during your examination, and what are the things you always have to answer. Okay, so first thing, what CT scan actually does in the radiological aspect of a case for COM. So these 5 points are very important. First, to know the anatomy. Second is the optimum diagnosis for certain type of cases, not for each and every cases, because CT is not primarily for diagnosis, but it gives some clues. Second, surgical planning, minimize complications and maximizing the results. So these are the important factors for what? Every time we used to do a CT scan, and first we have discussed if you have the opportunity to do a CT scan in a COM case, every time nowadays we have to do the CT scan. But here is my question, if you don't have the opportunity to do CT scan for all the patients, then which are the candidates you will choose for a CT scan or HSCT? Which is the, where is the, please give her.
So in cases of pediatric cholesteatoma, in such cases we'll be doing CT scan. In cases where we are expecting COM squamous associated with intracranial complications, in such cases we'll be doing, and to rule out the other complications of COM squamous.
So complications, pediatric patients and?
Post as revision surgery.
Revision surgery. Yeah. So any type of complication, intracranial, labyrinthine, then you will go for a CT scan. So these are the specific situations where CT scan is very, very important. Now, apart from CT scan, what are the modalities? So MRI is a very important. Nowadays, cone beam CT scan is also a very important topic. So in your recent advances, this can come as a question, what is the cone beam CT scan, what is the importance, and definitely for MRI. So we will discuss what is the importance of MRI in a case of COM. Anybody? Next, please tell me.
So for the restriction of the diffusion we can see, and also for the other intracranial complications.
So complications and
for the cholesteatoma, sir.
So cholesteatoma. So how can you diagnose a cholesteatoma out of MRI scan? What is the specific protocol or anything you have to write in your
diffusion weighted MRI.
Diffusion weighted MRI, non-EPI, non-ecoplanar, diffusion weighted MRI is a specification where we can actually diagnose a cholesteatoma, because cholesteatoma contains a high amount of water. So that is basically detected in non-API diffusion weighted MRI. Okay. Now, most important part, how will you see or evaluate a CT scan? Just seeing the plates or something else? What is your perception? How do you check this CT scan in your clinical setup? So the thing is, how will you evaluate the CT scan? How will you read the CT scan? Using the plates or something else, software or anything? And what is the difference? What is the utility of that?
I will use the plates.
You will use the plates. So we will check both the things here. Okay. So let's go. Before we check the plates, few important things. The basic three cuts are axial, coronal and sagittal. Okay. So every time you will check a CT scan, these three cuts should be present. Each and every one have some important information. Apart from the conventional planes, if your examiner asks what are the other planes or unconventional plane, there are two unconventional plane. One is transverse plane and one is Possel's plane. So these two planes are very important. Just keep in your mind, the Possel's view is important to identify the superior semicircular canal. In this cut, you can evaluate the whole superior semicircular canal. So if you have any type of disease or dehiscences, then this plane is very, very important. And for transverse plane, this is for the cochlea. If you have to evaluate the cochlea duct length or cochlea, then you have to check this transverse plane. So these two are unconventional planes. So you have 5 planes: axial, coronal, sagittal, 2 unconventional, Possel's and transverse view or transverse plane. Now, our case, what we have discussing from this morning, these COM patients. So can you actually can say what is the CT scan or what is the cuts? Can you point it?
Sir, this is a high resolution computed tomographic imaging of the temporal bone in 1 to 2 millimeter cut, mainly in the axial plane.
So, is this axial plane?
Coronal, sir.
No. So, this is coronal plane. This is coronal plane. This is also. So, this is our right side. This is the left side. So, coronal and the sagittals are the vertical planes. And now we are going to the next cut. This is the axial cut. So, first you have to visualize the axial cut and then you have to go for the coronal and the sagittal cut. So, here in these patients, a very important findings in these vertical cut is this part. What is this? This area? Maybe next person, you can answer.
Sir, there is less pneumatization of the mastoid area.
No,
and,
not less pneumatization. I'm not talking about pneumatization. What is this part, this area?
The dura tegmen
This
plate
is the area of tegmen.
Tegmen plate
Okay, so in this case, when we are evaluating the CT scan, the tegmen is completely eroded and there is a soft tissue completely inside the mastoid antrum. So, depending on the CT scan feature, what will be the differential diagnosis of your case? Apart from COM, seeing this CT scan, what are the things you will...
skull base osteomyelitis.
Osteomyelitis.
Temporal bone malignancy.
Maybe. First thing, there may be a complication of COM. Anything, anybody else? Please, if you have any other differential diagnosis.
Petrositis, sir.
Petrositis. Or?
And we can see the labyrinthitis and lateral sinus thrombophlebitis also.
Labyrinthitis. So, first thing, there was a polyp in the external auditory canal. So, whether this is a meningocele or herniation from vein, that must be confirmed. So, how will you confirm? So, this is the next modality of investigation.
Yes,
first, you have done this CT scan.
Yes, sir.
So, second is the
MRI.
MRI. contrast enhanced MRI is important to evaluate the skull base or the brain. So this is important. Whenever you have a mass like structure or polyp, so CT gives actually the density. So this is a homogeneous density inside the mastoid cavity. So from that we are speculating there may be cholesteatoma, there may be polyp, there may be granulation, whatever. But MRI, these intensities can be differentiated, and from there we can differentiate this is brain, this is granulation, this is cholesteatoma by non-MPI format. So the diagnosis can be reached by MRI. So whenever there is a skull base defect or this type of situation, we have to go for MRI. Okay, now we are just going for a DICOM viewer. From there we can visualize the whole CT scan. This is very important. Okay, so we are seeing the CT scan plates. So many plates in a single page, so it's very difficult to evaluate each and every microstructures. So for that you have to check the DICOM. Just follow. So this is the superior aspect. So whenever we are checking the axial curves, we have to start from the superior because there are the lesser structures or less important structure. So this is the petrous bone. This is the petrous bone, parietal part. So now we are coming inferiorly. This is the mastoid bone is coming. Okay. So this is the petrous apex. This is the cortex of the mastoid, and this is the first structures or the landmark here. Anybody take the mic? What is the structure?
Superior semicircular.
Very good. So this is the first structure you have to identify. This is the superior semicircular canal. Now we are coming below from superior semicircular canal. Posteriorly, what is this structure? Posterior semicircular canal. So everybody is aware of that. Every structures can be evaluated, but in a sequence. In CT plate, what we miss? So many sequence between the cuts. So these have to be evaluated through the software, and then you can visualize all the important structure. Now, what is this structure? Vestibular aqueduct. So this is the posterior semicircular canal, this is the vestibular aqueduct, and this is the vestibule. Here comes the cochlea. Here some ossicles you can visualize because this is the anterior part of the mastoid cavity, the epitympanum, and this is the mastoid. So inferiorly we are coming now. This is the, what is this part? This is the cochlea, and it is called stack of coin appearance. Very important. This is the basal turn view. Here is the basal turn of the cochlea, this is the middle turn, and this is the apical turn. Okay. So there is a stack of coin appearance that can be visualized, and here we can say this is the 2.5 turn cochlea can be seen here. So now we are going slightly up, and this is the cochlea, but this is slightly different view. This is called mid-modulus view. So here is the aperture where the cochlear nerve enters into the modulus. You can visualize there is a slight intensity in this part. This is the modulus, and these are the ducts of the cochlea. This is the cochlear duct. So here is the cochlea. So these are the inner ear structures what we are visualizing. Now come to the ossicles, very important in respect to the COM cases or your day-to-day questions. So where, what is this? Anybody else? Please take a mic, so that will be very give you clear. You tell me, what is this?
Long process of incus.
What is this called? This view?
Ice cream cone.
Ice cream cone sign. So to evaluate the ossicles, this is the first thing, the ice cream cone sign. The cone is, this cone part is body of the incus with the short process, and the ice cream part is basically the head of the malleus. Okay. So this is the ice cream cone sign. If you go slightly in the inferior part or towards the hypotympanum, then you will get two dots. This is called two dot sign. And slightly more inferior, there will be two lines. This is the two lines. So this ice cream cone, 2 dots and 2 line, if we get these 3 anatomical landmarks on CT scan, then we will be very sure that the ossicular chain is preserved. Okay. So this is the ossicular chain. And now one more important thing, we have diagnosed the aqueduct here, and what is this part? Anybody? This is cochlear aqueduct. So always keep in your mind the cochlear aqueduct transects the axis of the temporal bone, and this will be the parallel to the temporal bone. Okay. So any part of the mastoid that can be properly evaluated in this CT scan software. And one more important thing I want to discuss just before we can conclude this CT scan session, this is called this empire view, or seeing all these panels, this coronal, axial and sagittal in a single frame. This is more important because this actually reading the CT in other reformated planes like sagittal and coronal is slightly difficult to understand. So whenever you have any queries like this is the basal turn of cochlea in the basal part, so we can put this cursor here and all the curves, this is in the coronal section, this is in the sagittal section. Just like a navigation, you will identify these structures in the other reformated planes. Nobody has to give you the directions, you just put this cursor over there. If this is a ice cream cone sign, so how this looks like in other aspects, then you can just put, and this is the head of the malleus, this is the head of the malleus in the sagittal scan. So all these planes are very much important, though we always try to see the axial card, this is the basic part, but always try to evaluate the sagittal and the coronal card, because in our case, if we only see the axial card, then we can miss this tegmen leak, because there is erosion of tegmen and that should be visualized in the vertical card, either a coronal or sagittal card. So always try to check your CT scan in this format, and all these points you have to evaluate. Okay. So I must conclude with that. Okay. Thank you.
That was an excellent session. Now we will continue with our treatment part. So treatment options and microsurgical options will be dealt with by Professor Subhashachi Gon.
So now before deciding on the treatment part, let us again recapitulate what we have gone so far. So the provisional diagnosis, you have to say in the examination as advised by Professor Bandopadhyay sir, like chronic otitis media, squamous type, and then right and left one by one with complication if that is present, hearing loss if there is any presence, or fistula if you are suspecting any, you have to say that. So we are just breaking all the findings here, all the diagnosis here. For the right ear, this is active complicated squamous disease. There is extensive attic and the mastoid disease. Oral polyp is present there. There is severe mixed hearing loss and a suspected lateral semicircular canal fistula. This is the diagnosis for the right ear. And for the left ear, this is inactive squamous disease with moderate conductive hearing loss. So for the treatment, as told by Dr. Soikot, that treatment management has got two parts. One is investigation, another is treatment. So investigation part is over, now we are in the treatment. So what will be the initial treatment? For every treatment options, initial or final or definitive treatment, you should have one objective or aim in your mind what you are going to offer by that treatment. So what should be the objective of initial management or initial treatment? Anyone? Where we finished? কোথায় শেষ হয়েছিল? Yes, start please. So in this patient, where the patient is presenting with right-sided active squamosal disease with dizziness, what should be the initial management?
Sir,
please use the mic. Please use the mic.
Yes. Sir, the management, our first target would be to
symptomatic relief, like the dizziness, you have to.
Yes, so
address
stabilize the
dizziness.
patient first.
Yes.
Stabilize the patient first. After that,
And then, sir, we have to.
any other aim or objective that you have in your mind for the initial treatment?
To get the ear dry.
You have to confirm the diagnosis.
Diagnosis for otoscopy.
Yes. Next to you. So, how you are going to achieve that? Stabilizing the patient and coming to or confirming the diagnosis, or going to know the extent of the disease.
So I have to conduct routine audiological examinations.
Yes. So, everything that has been done till now, stabilize the patient, confirm your diagnosis, then define the disease extent. You read the CT scan once again, prevent further labyrinthine injury and prepare for the surgery.
Yes.
Always remember that cholesteatoma is a surgical disease, and you have to counsel patients and their relatives in that way, in that line. So how you are going to achieve that? The initial management by examination under microscope and suction and cleaning, number 1, and number 2, antibiotics, topical and systemic, and vestibular suppression for a shorter period, not for longer time. Alright. So antibiotics, the selection of the antibiotic will depend on the organisms that causes
Oral culture, sir.
oral culture. But what are the organisms? Next please. What are the organisms responsible for squamous otitis media?
This is Pseudomonas aeruginosa.
Please use the mic.
Pseudomonas.
Pseudomonas, anything else?
Streptococcus, then Haemophilus influenza, Morax, and
Squamous disease, please.
anaerobes.
Yes, aerobes and anaerobes. So you have to divide it in aerobes and anaerobes. So aerobes are Pseudomonas, you said.
Streptococcus,
No, E. coli,
Moraxella,
Proteus, okay, Klebsiella, alright, and anaerobes, bacterioids, Clostridium, okay. Now, what are the options we have for definitive management? Now, we have ready the patient is ready for the surgery. So, what are the options? Here also you have to think in your mind what are the options or what are the aims and objectives of the definitive treatment.
So,
Next please.
So the main in the definitive treatment is the removal of the disease, the
Yes,
first and
eradication
foremost
of the disease. Eradication of the disease is the first line. Next.
And then if we after seeing the
Then
extent,
what you are going to achieve from that? Eradication of the disease will lead to what?
any further
A safe and a dry ear. Right, very good. And next.
And we will also see for any complication that has been happening.
Yes, to prevent the
complications.
Yes,
Okay.
next.
And then the type of surgery that will be going.
That we will discuss. But any other aim that you have?
sir, after eradication, we have to look for the hearing reconstruction has to be
No,
done.
no, we are going to that later. But let us first discuss regarding the aims. We have already discussed regarding that we are going to eradicate the disease, number 1, and number 2, we are going to have a safe and dry ear. Number 3, prevention of complications, and then so that there should not be any recurrence. So, prevention of recurrence also, and a epithelialized, well epithelialized, self-cleaning ear, that is the objective, right? How we are going to do that? So, there are two parts, one is, and another aim is preservation or restoration or improvement of the hearing, right? So, how we are going to do that? One is eradication of the disease. How you are going to eradicate the disease? What are the options that you have? Not in this patient, but overall, what are the options you have in your mind?
So we have the two approaches, that is canal wall up or canal wall down mastectomies can be done.
Anything else?
And
Please madam, anything else? If the disease is limited, then now if we are talking regarding canal wall up and canal wall down surgeries if the disease is extensive, but if the disease is very much limited to the only attic area, like for the left ear, atticotomy or atticoantrostomy, and for the restoration reconstruction or hearing, what are the options?
To restore hearing.
Please use the mic.
To restore hearing. To restore hearing.
Restoring, how you are going to achieve that? By doing After
Sir,
doing mastectomy, ossiculoplasty and
reconstruction.
tympanoplasty and also another thing is concomitoplasty or meatoplasty. So these are all written here. You have answered all of them. Now let us discuss what is atticotomy or atticoantrostomy. Please, next one please. What is atticotomy or atticoantrostomy?
Sir, we cleared the attic, any disease.
This is done only for the limited diseases. Yes. First thing is this is a surgical procedure done for the limited disease in the attic area or going just up to the antrum. So atticotomy and atticostomy. What do you do there? What is done?
We cleared the attic area and
how you
established the
clear?
ventilation.
How you clear?
We curate the attic region.
No, anyone? Chalo, next. How you do that? So attic has got a lateral boundary. What is that? What is the lateral? Sir, lateral part of the attic is found by
the Inca.
No, not incus. A bony wall.
So scutum.
Scutum.
So bony lateral bony attic wall. Okay, that is known as scutum. So you have to remove that.
Yeah.
Okay, by drilling you have to remove the lateral attic wall. Then you get into attic. Otherwise you cannot reach the attic, isn't it? Then you remove the disease from there. And what do you do after that? Do you keep it open? What do you do? If you keep it open, then what is this surgery known as? What if you keep the attic area open? This was done very long back. If you read the history, that is known as Bondi's surgery. Okay, that is known as Bondi's surgery. If you do atticotomy and leave the area open, that is Bondi's surgery. But what we do nowadays, we reconstruct the attic wall, lateral attic wall by what? Cartilage and perichondrium and periosteum. Okay. So this can be done isolated for a limited disease, or it can be a part of canal wall up or canal wall down surgery, right? This atticoantrostomy can be a isolated procedure for a limited disease, or for extensive disease you can do this as a part of the canal wall up or canal wall down surgery. Now we are in the canal wall up and canal wall down mastectomy. For extensive disease in the middle ear, attic and the mastoid, there are two schools of thought. Some people do canal wall down surgery, some people prefer canal wall up surgery, and both have some advantages and disadvantages. That is theoretical, you know that, you have read that. Now tell me, what are the definition of canal wall up surgery? What do you mean by that? And what is the difference between canal wall up mastectomy and the cortical mastectomy? Many people write cortical mastectomy and many people write canal wall up mastectomy. What is the difference between these two? Let us first start with cortical mastectomy. Next one please. What is the cortical mastectomy? Please, cortical সবাই জানে.
Sir, in cortical mastectomy, we all the accessible cortical air cells of the mastoid are exteriorized.
Cortical air cells, what is that?
Mastoid air cells.
So first is mastoid antrum and all the accessible. You have to use this adjective. Accessible mastoid air cells.
Are
you excentrate all of them and then you create a single cavity. Why? What you do not disturb? Posterior canal wall. You keep that intact. Okay. Yes, so that is cortical mastectomy. So what is canal wall up mastectomy then? This is also known as intact canal wall mastectomy or combined approach tympanoplasty. All these things are similar. Canal wall up mastectomy, intact canal wall mastectomy, or combined approach tympanoplasty.
Sir, in canal wall up mastectomy, in addition to exteriorizing all the accessible mastoid air cells, we clear all the disease from the attic, antrum.
Antrum is already clear.
Sorry, attic also. The entire the disease is cleared from the.
Next one. There are two more procedures has to be done along with this. What are those two? This is a hint.
Ossiculoplasty.
No. Ossiculoplasty, yes, obviously ossiculoplasty you will do.
Meatoplasty.
Before that, posterior tympanotomy. So, posterior tympanotomy you have to do because you have to eradicate the disease from the mastoid, from the middle ear, from the attic, right? Along with canal wall mastoidectomy, you can do atticotomy to remove the disease from the attic. But what about the middle ear? The posterior retrotympanum area, you have to remove the disease from there. For that, you have to do posterior tympanotomy. So, what is posterior tympanotomy?
You have to approach the facial recess area through the.
What is the boundary of facial recess?
Sir, it is superiorly bounded by incaudal buttress, inferiorly by the chordofacial angle, laterally by the chorda tympani nerve, and medially by the facial.
Very good. So, here as the examiner will ask you regarding the boundary of the facial recess, boundary of the sinus tympani, what are the types of sinus tympani, subiculum, ponticulum, all these things can be on the retrotympanum, they can ask. The examiner can ask all these things to you. So, canal wall up mastoidectomy means cortical, extended cortical mastoidectomy and making the posterior canal wall thin but intact. Number 2 is posterior tympanotomy and number 3 is transcanal tympanoplasty plus minus ossiculoplasty. Okay, transcanal tympanoplasty and ossiculoplasty. Now, canal wall down mastoidectomy. What is canal wall down mastoidectomy? Next, please.
So, canal wall down mastoidectomy is cortical mastoidectomy. After that, we will do the posterior meatal down the posterior meatal wall.
We will remove the posterior canal wall, lower the posterior canal wall,
and make the middle ear
cleft. How you are going to do that? How you are going to remove the posterior canal wall?
Sir, by
there are two components here also. What are those components? One is lowering the facial reach and another is breaking. What is breaking? What do you want to break? Facial bridge and anterior and posterior buttress. Okay. So, how do you achieve that posterior canal wall removal? By lowering the facial ridge and by removal of the facial bridge and the anterior and the posterior buttress. Now, you can see the whole attic area also. And what you have done by this? You have made it a single cavity by joining the mastoid, antrum, mastoid air cells, attic and the middle ear. You have formed a single cavity. Okay. What are the parts of canal wall down? What are the types of canal wall down mastoidectomy? There are two types. One is
radical mastoidectomy. Modified radical mastoidectomy.
Modified radical mastoidectomy. Another is
radical mastoidectomy.
Radical mastoidectomy. So, in modified radical mastoidectomy, what do you do apart from this? Lowering of the facial ridge, breaking or removal of the bridge and anterior posterior buttress is common to both the procedures. Now, we are dividing into modified radical and radical. So, in modified radical, what else do you do? Next, please.
So, will preserve the mucosa of the middle ear cavity.
Now, what do you do? Preserve. And what do you do? Anything else you do? Remove the diseased. Aroto disease apart from cholesteatoma, there will be diseases. The tympanic membrane, diseased part of the tympanic membrane you have to remove. Diseased ossicle also you have to remove. Okay, if the epithelium is very much adherent to the head of the malleus or the remnant part of the body of the incus, you have to remove that also, na? So, diseased ossicle and diseased tympanic membrane you have to remove. And next is reconstruction, tympanoplasty, ossiculoplasty, after that concomitoplasty. Okay. And what do you do in radical?
Sir, in case of radical mastoidectomy, we remove all of the mucosa along with ossicles and.
What ossicles do you remove?
Malleus and incus. If the stapes suprastructure is present, then we try to preserve it and we occlude
what you are going to preserve? Stapes superstructure?
Oval window.
Oval window.
Stapes foot plate.
Stapes foot plate. So, stapes foot plate, apart from stapes foot plate, all the ossicles are removed, irrespective of they are diseased or not. Everything will be removed. And next is removed all the tympanic membrane. Remnant tympanic membrane is all out. Everything will be removed, irrespective they are diseased or not. And what else you are going to remove? the mucoperiosteal lining of the middle ear cleft. Whatever is there, you have to remove that. And then you have to
occlude the eustachian tube opening.
Occlude the eustachian tube opening. So that completes your radical mastoidectomy. So for this patient, what surgery do you suggest? Next please. Now coming to this patient, what surgery do you suggest for this patient?
Sir, we will go for canal wall down surgery. So we will go for canal wall down surgery as the disease is extensive. Sir, and we'll also do the conchomyoplasty.
Okay. This is for which ear? Because
so right
both the ear are diseased.
So we will go for the right ear.
Right ear.
That is
okay. Anything else? So canal wall canal wall down mastoidectomy. You forgot one thing. What?
Repair of the
labyrinthine fistula. So you have to repair
we will cover
that.
the defect, yes, sir.
Okay.
With the cartilage.
And whenever if there is labyrinthine fistula, you have to remember the classification of fistula. Remember now? Yes. That you have to remember. I am not discussing because there is lack of time here. I am not going to discuss how the surgery for the labyrinthine fistula is done. You have to read that also. Underwater surgery, okay. Why the matrix should not be removed at the beginning of the surgery, why it should be done at the last end, and why it is done underwater, okay. And why when multi-layer reconstruction is necessary, you have to read that in detail. Tympanoplasty and ossiculoplasty. Why canal wall down mastoidectomy here? Because disease is extensive, there is positive fistula test and suspected lateral semicircular canal fistula. For the left ear, what do you suggest? For the left ear, what do you suggest? Do you do the surgery of both ear at same time?
No, sir. At least 6 months of gap is to be needed.
At least 6 months. Why 6 months of time is important?
So after the OT, there can be an essential component coming in the ear. So we need to wait for like 6 months to see if there
Tell
is.
me one investigation that you want to do after right ear surgery, before left ear, before proceeding to left ear surgery. One investigation that comes into your mind that this has to be done. So you must know that. Considering left ear is inactive squamosal disease, that's not active. So what you should know before proceeding for surgery to the left ear? The audiogram. You must know that right ear has not gone fully dead. If the right ear is dead, then for left ear you have to observe. You cannot go for surgery for the left ear, alright, till it becomes active. So for left ear, atticotomy or atticoanterostomy, reach up to the fundus of the posterior superior retraction pouch, excise the retraction pouch and then repair the defect by temporally fossa or by cartilage. At the same time, why this has happened? Due to the dysventilation. So you have to know all the theories of cholesteatoma formation. Apart from all the 4 traditional, there are other dysventilation, there are mucosal coupling. All these theories you must read, because in post graduation examiner might ask you. So you have to restore the ventilation pathway also, okay. And at the same time tympanoplasty or ossiculoplasty may also be needed, because there is retraction pouch which will destroy the long process of the incus, alright. So ossiculoplasty is needed. Now would you prefer to grow from anterior to posterior or posterior to anterior? Anterior to posterior, that means inside out, and posterior to anterior means doing cortical mastoidectomy first and then proceeding towards the attic and the middle ear. So what will be your preference? Next please. For the right ear. Posterior to anterior usually done under microscope, and this is a classical mastoidectomy approach. So what approach you want to?
Inside out.
Inside out. Okay. What are the points in favor of doing inside out approach here? Next please. What will be your, what will
right
be?
ear, I would like to go for posterior to anterior.
First, why sir?
So I would follow the cholesteatoma sac, and so that whether I need to go for a canal down or not.
Don't say follow the cholesteatoma sac, because we know cholesteatoma originated from the posterior superior area or the attic area. So you are not following. If you are following, then this is inside out approach. Okay. Next. So this is One is anatomy, you are well aware of the anatomy. This is safer because you are not near to any important structures. Alright. And what are the points in favor of inside out when you want to do inside out approach or anterior to posterior approach?
So for
when the disease is limited.
Atticoendostomy, I would like to go for
When the disease is limited, and that can be done with the help of microscope or endoscope, both. Okay. So posterior to anterior is microscope, classical mastectomy also known. This excellent orientation, safe, good cortical exposure and preferred in extensive disease. So right here extensive disease, so posterior to anterior approach is preferred here. Disadvantages, disease hidden in the anterior initially. At the end you remove the anterior. And anterior to posterior, it can be done microscopic or endoscopic, both. Advantages, early attic disease removal and preferred in limited disease. Disadvantages is limited space, you need very good experience before doing inside out approach. You should do some posterior to anterior approach first, some of the surgeries, after that you start doing anterior to posterior approach. Now what are the, we will go very fast with this because these are all theoretical. What are the difficulties next? You have seen or managed in mastoid surgeries. The difficulties can be anatomical or it can be disease related. So what are the anatomical difficulties that can be, that you have seen or managed?
There might be any kind of facial nerve injury.
Facial nerve dehiscence.
Sorry.
This is anatomical, facial nerve dehiscence, congenital dehiscence. Next, there are three sides, one is up, one is posterior, another is inferior. So above there is one line, tegmen. So it can be,
there might be injury to the dura, actually the tegmen injury.
Tegmen, not injury, this is anatomical deformity. So this can be low lying dura.
Low lying,
or it can be forward lying sigmoid sinus,
and
or it can be
high
jugular bulb high up. Very good. It can be a contracted mastoid. Okay. So these are the anatomical difficulties that can be seen. Or corner septum. You must know regarding corner septum or petrosquamosal septum. The examiner will definitely ask about corner septums and how you are going to manage that. Now disease related challenges, if there is extensive cholesteatoma, if there is granulation, there will be bleeding. If lateral semicircular canal fistula, if there is facial nerve exposure, if there is dense adhesion or revision surgery, these are the difficulties. Now regarding complications, complications can be peroperative or can be post-operative. So peroperative, all the important structures that are there that can be injured, like facial nerve. Okay, there can be sigmoid sinus injury, there can be dural injury, and the CSF leak. All these things can happen. And post-operative, you are well aware, you must read about all these things. Early complications and late complications, as the time is short, I am rushing through. Early is vertigo, sensorineural hearing loss, facial weaknesses or infection. These are the early complications. The late complications can be residual cholesteatoma or recurrence, or there can be cavity issues, meatal stenosis or persistent discharge. Okay, thank you. These are the key take-home messages. Please read them before the other speaker comes.
You must also counsel the patient before you undertake any management. You must inform the patient. So Dr. Ajay Khawas will be talking about counseling very shortly.
Already you know the discussion part from the disease and what are the surgery you have planned and everything you know. So for the counseling of the patient is very important nowadays, and that's why in the undergraduate as well as the postgraduate the outcome module is coming already in the implementation. So you have to, for the counseling, two part. One is the informed consent, one other is the leaflet. In the leaflet, what you should give to the patients about the information of the disease. The disease information that you give, what is cholesteatoma, what is the treatment options, what is mastoidectomy, and what are the benefit of the surgery and alternative treatment. This should be given as a leaflet to the patient for the patient information. Next is the what are the surgery complications already discussed that you should discuss with the patients, and these are the points you should tell before you go for the surgery. And these points you should already discussed in the Dr. Gaun already discussed, you should mention as a leaflet. Next is the informed consent. Our AY already have, there is a, you can download from the ayho.org about the consent form. That consent form I have given here. For the squamosal disease, the separate consent form is there. You can take and download it and take as a consent. This is the part of the consent form. So now come to the Dr. Jayanta Shah.
Dr. Jayanta Shah with role of endoscopes in management of chronic otitis media.
What are the types of endoscopes we usually use? Will volunteer? Anyone? On.
0 degree endoscope and also angled endoscope 30 degree and 70 degree.
Yes, 0 degree for wide panoramic view and for angled.
30 degree, 70 degree.
Yes, 2.7 or 3 mm we usually use, but occasionally 4 mm also.
4 mm also.
Yeah. How to reduce thermal damage?
Constant irrigation during drilling underwater.
For endoscopic use,
For
during
endoscopic.
endoscopic use, not for drilling. Next. Time is too short.
We will reduce the intensity of light.
We should use LED light source and intermittent removal of the endoscope from the surgical field. Okay. Next. How to reduce the recidivism?
Actually, using the endoscope, it's more exposure to the hidden areas like the sinus.
Yes. What are the hidden areas?
Sinus tympani, anterior epitympanic recess. Around the perifacial region will be better visualized using the angled endoscope. So recurrence will be reduced if we remove the.
With this panoramic view and wider image and direct visualization of the cornerstone of that site. Okay. Actually, type C sinus tympani is more important. How do you assess the patency of the ventilation pathways through the endoscope, through the help of endoscope?
Sir, to assess the recess supratubular area, to mucosal and to assess the mucosal folds and
yes, whether there is any fibrosis or any granulation tissue or any cholesteatoma or any kind of bands present in that area. That hidden areas, anterior isthmus, posterior isthmus, okay. When to switch over endoscopic procedure to microscopic, in what conditions do you expect?
Sir, when we cannot reach the disease area and where there is complication like
extensive disease. Paraoperatively, when you found that there is extensive disease, so you have to extensive drilling there is needed and more common excessive bleeding.
Yes, sir.
Hello. Next part is the myotoplasty. Will be discussed by Dr. Ajay Mollik.
Okay, these questions are there. If you are naturally, it's in a case of canal wall down, which we are doing in the right side. So, how do you plan for your myotoplasty? Next person. Quick. What is the planning which you will think of doing?
The question is that you are doing the canal wall down mastectomy, so you have to do the myotoplasty. So what is your plan regarding the myotoplasty?
Anybody next? Carry on.
Give some hints, otherwise
So
they
we
are.
plan for a wide myoplasty so that after
Yeah.
the when the patient comes for a follow-up, we can see the entire cavity
Yes.
in a single view.
Very good.
And
Also,
So, basically, you can
clean the cavity after the.
self-cleaning cavity.
you should be able to clean the cavity at a later stage. You should be able to see inside for any recurrence of the disease. Okay, so you should be able to have a panoramic view of the complete mastoid bowl which you have, operated upon. The complete field you should see. Now, how mastoidectomy helps in canal wall down? How does it help?
Sir, the self-cleaning nature, and we can view the thing and suction.
Why do you basically do it? One.
Suction for the
We have answered
wax,
it most of
when
it.
wax
Yeah, you
gets
remove any
cut.
debris.
Debris.
Good. Second, visualize for
Visualize any residual disease or
any
discharge.
recurrence disease and all that. You have to do for that reason. Now, so basically it is a step which is performed to widen the external canal and make it continuous. Basically, you make one single cavity, isn't it? The mastoid and the middle ear are made into one cavity, so that the whole area can be seen. Correct? And what are the advantages of a good myoplasty? We have already discussed, I think, most of it. Now, this is the answer. It provides adequate ventilation, right? Second, any debris collection can be removed. It helps the surgeon to identify any residual, and it helps in the rapid epithelialization. Okay, so we have covered these 4 points. Okay, so these are the advantages. Next is, what are the issues to be kept in mind? Okay, this is what are the issues to be kept in mind. Like what you have to be careful of while doing myoplasty.
Proper suture and closure.
See, yeah, you should try to avoid that any bone and cartilage is not exposed when you're closing, because that is going to incite some granulation formation. Second, when you have the edge of the conchal cartilage, sometimes that projects into when you're trying to clean. So please remove that edge of the conchal cartilage. Okay, that is very important. And avoid any bone, like we have also said, cover every kind of bone and cartilage which is exposed, and inadequate circumference of the skin should predispose to stenosis. See that it is nice and wide. How do you know it is wide enough? Or wherever it is going.
Sir, we can see the entire canal wall down cavity.
Yeah, so when you're operating, you come to know, you're seeing the whole cavity yourself, okay? Right? So you should be able to make that out. Now, okay. Now, can you tell me some of the common steps, common named procedures?
Sir, we have to remove the floor cartilage and the
Names of myoplasty.
Different types of myoplasty.
Types of myoplasty, somebody's names. Yeah. So, then one more question. Yeah, can you tell the names? Just 1 or 2 names.
So, staircase myoplasty, fish myoplasty.
Yeah, there is a long list. You just say you're following one of them, right? Now, one more common question which can come, which one you do, how do you do it? There are various types of myoplasty doing it. You say the steps which you have seen in your institute and say this is the steps we follow in my institute, we follow this, right? This is the steps which we are doing. There are many methods, everybody has their own techniques of doing it. So you just give one straight answer, in my institute we follow this, right? And anything?
Okay.
Nothing else is there. Thank you. Any questions on myoplasty? Anything you want to know?
Okay,
this
presentation will be shared in your group. I don't, if you questions, you can also ask in the group. Now come to the Dr. Soikat Somadar regarding the hearing improvement. How will you?
So this session will be on how to optimize your hearing outcome in a canal wall down mastoidectomy. Mostly a canal wall down mastoidectomy today we will discuss because we are discussing this case only. So who is having the microphone? Please let me know. Yeah, give it to someone. So what determines ossicular reconstruction in your patient, in this patient? So you have operated the which ear? Operation has been done left ear.
Right
So
here, sir.
right here, a right ear canal wall down mastectomy has been done. Now you are preparing for ossiculoplasty. So what are the things that you will keep in mind, or what are the things that you will see in your surgical field that will direct your surgical intervention, the ossiculoplasty intervention?
Sir, according to the presence or absence of stapes suprastructure.
Very good. The most important thing, stapes. Very good. So presence or absence of stapes superstructure. If the stapes superstructure is absent, then the next thing that you will see is?
Sir, if it is absent, then we can give a boomerang cartilage.
If it is absent, then what will you see?
Oh, then we can see a foot plate, sir. Direct.
Foot plate. What is the thing that you will check in the foot plate?
So its mobility is present or
Very
not.
good. So first thing that you should note is the presence of stapes superstructure. Second thing, if it is absent, then a mobile stapes foot plate is present or not. These are the first two very important things. The next thing, the third thing, pass it on to Bhaskar. The next thing that will determine your surgical process.
So first the ossicle and
That has been already determined whether stapes superstructure is present or not. The next thing, you need to see a nerve.
so face
Very good. The relation to the level of the horizontal facial nerve. What is the height with relation to the level of the horizontal facial nerve? Because the principle is when you do a ossiculoplasty, you also try to create a space. If the horizontal facial nerve, the height is high, then you need to create a more of a space. If it is low, then less space is created. Fine. So for this, I would request you all to go through the ossicular chain reconstruction chapter in Shambo's surgery of the year. In Shambo's surgery of the year, it is given in great details. Now, what is the principle of, or what is the Austin classification of ossicular defect? Microphone, you.
Sir, there are 0 means all ossicles are present. A means
Right.
there are incus absent. Malleus present.
Correct kore dei. He stands corrected over here is, there is no mention about the character of the incus in Austin's classification. Incus niye we do not need to comment. We need to comment only on two things. What are the two things?
Malleus as stapes.
একজন মেলিয়াস
Malleus as stapes.
মেলিয়াস
As stapes.
ভালো ছেলে আর এভারেজ ছেলের মধ্যে এটা ডিফারেন্স মেলিয়াসের
Stapes suprastructure.
হ্যান্ডেল অফ দ্য মেলিয়াস অলওয়েজ মেনশন হ্যান্ডেল অফ দ্য মেলিয়াস and stapes superstructure, not stapes. So if handle of the malleus is eroded, it will be M minus, even if the neck and head is present. ठीक है? If stapes superstructure is absent but only foot plate is present, it will be stapes S minus. Very good. Next one. So that will be A, B, C and D. A will be both plus, B and C will be 1 plus 1 minus, and D will be both minus, M minus, S minus. Fine. So what kind of ossiculoplasty you will be doing in these cases? I am asking you about modified Woolsten's classification of ossiculoplasty. Type 1, madam? Type 1 ossiculoplasty. What it is?
We replace the malleus by either refashion cartilage or prosthesis.
Type 1 is nothing but myringoplasty. It is only myringoplasty. Type 2?
Type 2 is when the handle of malleus is eroded, then we reconstruct.
Whenever you are telling about modified Woolsten's classification of ossiculoplasty, you say where the graft is placed. Etar beshi kichu noy.
The
So
graft
type 2
is placed over the incus.
Over the remnant malleus or draped over the long process of the incus. এর বাইরে কিছু নয়. Type 3, next one, Sujata. Type 3.
So it is over the stapes.
Type 3 is placed over the stapes superstructure. If the capitulum is present, then it will
short columella.
It will be short columella or a
Long.
cord. And if
Cord.
superstructure is absent, then it will be a
Long columella.
major columella or a torp. Fine. Type 4.
Over the oval windows.
Yes. So another term is myringo-platinopexy. So the graft is directly placed over the mobile foot plate. And the round window is shielded so as to maintain what?
Phase difference between.
Very good. And type 5? Swarnabha? Type 5?
It's a lateral semicircular canal, fenestration of.
It is called fenestration,
Fenestration
but
surgery.
according to Shambhu's surgery of the year, this fenestration will not be done by you. Already the disease has caused the erosion of the bony canal, the lateral canal, and you are placing either a graft over the eroded canal or you are leaving behind a cholesteatoma matrix, a short cholesteatoma matrix, which will act as a sound transmission pathway. And the round window has to be
closed.
Shielded, not closed.
Shielded.
Has to be shielded. And type 6, if anyone can say, next to you. Type 6.
Inverse.
Sono inversion, where the sound transmission takes place from the round window, but this is actually not placed in Woolsten's classification or modified Woolsten's classification. What is the character of the material that you would like to use for ossiculoplasty? Character of the material, next one.
That is the prosthesis.
Yes, character of the prosthesis. Take the microphone. Stand up, Anna. Character of the prosthesis.
We can use Teflon prosthesis.
Character, not the name. Bio, it should be bio-inert. Next, it should be
It should not cause any
Bio.
foreign body reaction.
that is bio-inert. It should be bio-compatible.
Compatible.
And third is good osseointegration property. It should have good osseointegration property. Ar ki hote hobe? It should be light. It should have a good tensile strength.
Durable.
It should be either good malleable so that you can carve it out properly, and preparation has to be easy. ठीक है? Another principle for ossiculoplasty you all know, tracks. So what is the full form of these tracks? One next to you. Yes, madam, go ahead. This is the mechanics of middle ear reconstruction. Mechanics. Tracks, yes. Tension, next. Go through it. Tension, round, angle, center, and space. What should be the space?
Middle ear space.
Middle ear volume koto hai?
1
ml. You should try to at least give 0.5 to 1 ml of space. Thank you.
Okay. The otology recent advance will be taken by Dr. Arindam Das.
So many things included in recent advance in otology, even in ear, nose, throat, and every aspect. So it's beyond our time limitation. We cannot discuss each and everything. So first thing, last year we have documented all these recent advances, and we have shared the PDF in this group, and this time this will be shared. So each and every topic we are not going to discuss here because there is a time duration of 10 minutes or like that. So few important things we will discuss. First thing, cochlear implantation is recent advances in otology for last 10-15 years. So every time we have to get some questions on recent advance. Now there is the ABI and so many things. So we are not going to discuss this cochlear implantation, what are the steps, indications, you all know that. Now few important things like what are the major complications that can happen in a case of cochlear implantation surgery that you have to know. So there may be some major complications, there are some minor complications, and there is some complication that is related to the devices. Major complications, meningitis, CS oblique, facial nerve paralysis, severe facial nerve stimulation, hematoma formation, mastoiditis, cholesteatoma, even after 2-3 years after surgery, skin necrosis, extrusion. There is a long list of complications just like any surgery, so you have to read it, and in your papers, if there, you can question that. Minor complications, these are more common, the choroid tympani nerve injury that happens during the classical cochlear implantation, because we have just discussed the facial nerve anatomy and the facial recess anatomy. The chorda tympani nerve may be injured. A lot of other complications like anterior swelling, hemifacial swelling, retroauricular, minor wound. Otitis media is very common after cochlear implantation due to blockage of the ventilation pathway during the surgery. Vertigo, definitely in the adult patient, vertigo is more common nowadays. And device failure, there are two types of failure. One is hard failure, one is soft failure. So hard failure means there is a definite problem in the hardware related issue in the internal receiver stimulator that is not properly working after surgery. So this is a very critical condition. Majority of the time we have to replace the device and call for the previous implantation surgery. Soft failure is related to the software and the communication issues. Most of the time that can be sorted by the software and the programming part or the mapping. Okay. So these are the, so one more important thing is the electroacoustic stimulation or hybrid CI. In some of your examination these questions can come. So in cochlear implantation what we do, we just insert a electrode inside the scala tympani of the cochlea. But if the patients have a preserved hearing in the low frequency, just look like this PTA or the audiogram. If the low frequency is preserved and the high frequency is damaged in any patients, because majority of the adult patients we found this type of skew-shaped audiogram in this type, and then the high frequency may be implanted, leaving the low frequency that can be stimulated by the auditory stimulation. Because implantation sound is sometimes a metallic sound or is a difference from the natural sound. So if the low frequency can be stimulated by the natural sound, that gives the best long-term result for the patient. So in a case, if we use both the modality, cochlear implantation and the hearing aid, depending on the hearing result or the hearing defect in the patient, this is called hybrid CI or a electric acoustic stimulation, where the electrical stimulation by the cochlear implantation and the acoustic stimulation by the hearing aid can be done simultaneously. Okay. So the drug-eluting CI, the dexamethasone is incorporated inside the electrode. This is a recent advance in cochlear implantation where implantation is done. Then the post-implantation fibrosis or internal part of the cochlea, what happens in the next few 6 months or maybe 1 year of time, that can be minimized by using these drug-eluting electrodes during implantation. One more part is the TICI. This is called totally implantable cochlear implantation. So in this cochlear implantation, there is a two device. One part is a receiver stimulator, this is inside, and the other part is the BT stimulator, which is the outside, that actually captures the sound, processes it and send it inside. In TICI, the whole part is inside the skin. The major challenges was the receiving the sound stimulus, because the sound is coming from outside, there is a barrier of skin. So the sound stimulus is a barrier. There is a main difficulty in doing this TICI, and second is the lifelong battery. So this is the main reason for last 10-15 years we are reading this in the recent advances, but in real time we are not doing this in our patients because of these two type. There is some issues with FDI approvals also. Okay. Robotic implantation is also there. There is some robots that can be used during surgery of the implantation. But nowadays, the whole implantation is not done by the robotic surgery, but the insertion, that is very, very crucial part of this cochlear implantation surgery to minimize the intracochlear trauma, that can be minimized by the steady, slow insertion of the electrode, that only can be done using robot over a 9 minutes or 10 minutes of insertion. You put it on the robot, take a cup of coffee, and your insertion is complete within 10 minutes. So this is the idea of this robotic insertion. Okay. The other part is the regenerative medicine. Just give me 2 minutes. The regenerative medicine, this is also a very new things, and this is coming up. The how to regenerate during your surgery. Mostly the PRP is being used, FGA, fibroblast growth factors, and easily available nowadays, and they can be used to regenerate the tympanic membrane also. So these are the regenerative medicine used in tympanoplasty and as well as the gene therapy. That is also important. We have included all the things in this PPT and you will get it. So we will conclude with this much of the recent advance. If you have any questions, let's make it after completion of this year, if we can some time. You can ask me in the group also if you have any queries, because this is only the textbook teaching like thing, so there is nothing in discussing all this here. Okay, thank you.
So we have come to the end of the chronic otitis media session. If you have any queries, please take the microphone and ask your question, query, doubts, if you have any. If you do not have any right now, go through this chapter again at night, and if you find something doubtful or needs more explanation, you can put it in the group also. We will try to satisfy your queries. So if you have any queries, please take up the microphone and ask your question. And if you do not have any question, we have our questions. So
This is for
we
the
expect these
self-assessment.
10 questions to be answered in next 15 minutes. So these are the questions, and tell us if you know about all these questions, and if you need any answer for these questions, please be specific. We will discuss those questions only. Question 1, definition of chronic otitis media and classification. Where do OME and healed otitis media fit? The healed otitis media and OME, these are the inactive diseases. This active and inactive COM does not fit in here. And the list of tympanic membrane type of the tympanic membrane perforations, I think that should also not be discussed here. Abramson's definition of cholesteatoma and the list of theories of origin of cholesteatoma, outline the mechanism of bone erosion in cholesteatoma. We have discussed it in our previous session also, the triggers and mediators. Dr. Soposachi Gon has told you about all these things. Dr. Jayanto Saha. Dr. Jayanto Saha discussed about this mechanism of bone erosion in cholesteatoma, the routes by which an attic cholesteatoma spreads from the Sprusak space. What is Cole classification for cholesteatoma? What are the letters stand for? If you have queries, you just put it in front of us. The lateral oblique view of mastoids. We always compare both the mastoids when we go for the X-rays of skyograms. Enumerate the complications of COM under intratemporal, intracranial and extracranial headings. Compare the canal wall up and canal wall down procedure. Dr. Soposachi Gon has detailed discussion about the canal wall up and canal wall down procedures. And what is Belfast rule of thumb? How does the Mary score predict your outcome? So I think all these questions are known very much to you. Can anyone come to the last question? What is Cole classification? The CH is the cholesteatoma, O is the ossicular chain condition, and L is the life-threatening complications, extracranial, intracranial, and E is the eustachian tube function. So Cole classification is important. It is coined by the European Society of Otolaryngology, and you know about Cole classification. There are some diagrams also. You can draw the diagram with your answer if there is anything. The lateral oblique view, it gives you the idea about mastoid pneumatization, and also if there is any forward lying sinus or low lying dura, you can also have an idea. Now what is Belfast thumb rule? If the 2 years have significant difference in hearing. Whatever you do for 1 year will not be sufficient to satisfy the patient. So there should be some balance in the hearing sensitivity of both the ears. So this is the Belfast thumb rule. There should not be more than 30 decibel difference between the 2 ears in hearing sensitivity. Mary score, mid-ear risk index, no query.
Okay.
So you know everything, so we end it here.
Okay, thank you.
Thank you so much. We will be moving to rhinology. We will be moving on to rhinology.
Thank you, our moderators and panelists. I request Dr. Doipan Mukherjee to hand over the certificate to Dr. S.N. Bandopadhyay. আচ্ছা সবাই চটপট করে ফ্রেশ হয়ে চলে এসো, এখনই কিন্তু শুরু হবে। ডক্টর কর্নেল অজয় মল্লিক স্যার, ডক্টর অরিন্দম দাস, ডক্টর সৈকত সমাদ্দার, ডক্টর জয়ন্ত সাহা, ডক্টর সব্যসাচী গণ, ডক্টর অজয় কুমার খাওয়াস।